Dr. Rathmell, thank you so much for finding the time to talk with me. How's the job so far?
Oh, well, thank you. I've been looking forward to the chance to talk to you. So far, the job has been fantastic. I am having a really good time getting to know all the ins and outs of the NCI and all the people, really fabulous people who work here. The answer has to be fabulous.
Yeah, fantastic. Well, this is a really difficult time for NCI. I guess you don't really choose the time when you become director. This could be the worst year since sequestration financially. So you must be making some really difficult choices, broadly speaking. What are they?
Ah, so uh, so that's a hard pivot from me saying how fabulous the job is. I will still stand by that answer. So I guess first I'll say that in spite of this being a particularly difficult budget year, we still have an allocation of over $7 billion to work with. We are still, carrying this ball forward. We're looking forward to doing really exciting things in the cancer research arena. And um, with a tighter budget period, it gives us the opportunity to really think hard about what we do and make sure that we're prioritizing things very, very well and that we are um, doing what is best for the American public and for advancing really the best cancer research. So I see it um, as more of an opportunity for right now, and I'm here for the long haul. So this is you know, one year that we'll get through. I think we know that next year will be another challenging one, but really looking forward to continuing to have otherwise strong support from Congress.
Hmm. Well, it's an interesting question about timing because if you're going to make changes, uh, it's probably easier to make changes when times aren't good financially. Politically, it's easier. I mean, politically, internally, politically. Is that what you're seeing?
Well, it's easier to have a tough conversation when you're talking about real dollars and cents. So we have um, been talking really seriously about what things we're doing and where we're putting our funds. So absolutely, that part is true. But I think um, people are very aware of the budgetary challenges and are working very collaboratively to really think about how we you know continue. Some of the bigger priorities are uh, early career investigators in the workforce. That is unanimous, that people look for us to um, be able to prioritize uh, that group of investigators and clinicians.
I guess people who are either reading this or watching it are on pins and needles and they're going impatient. Why haven't you asked about the RO1s and the pay line? So I guess I should ask about the RO1s and the pay line.
Sure. So I absolutely prioritize RO1s as well. I was an RO1 funded investigator 3.5 months ago, and I know how important that is to individual PIs, to research programs, to departments and institutions around the country. I know that. Um, I have also been sitting on pins and needles for the budget to land and to be able to move the numbers on the spreadsheet so I know where we're going to be able to land. Um, it's a balance between setting the pay line for early stage investigators and also uh, honoring commitments to grants so that we um, don't overcut existing grants. And so we are still thick in those conversations. I'm hoping to have a um, set of principles out in time for AACR. So hopefully by next week we'll have some finals. But it takes a minute to get them all together, and we've had about a week to be working on this so far.
So what's the top line results? Is it going up? Is it going down?
So I can't answer that. I can tell you for today that I am very committed to preserving the um, uh, training branch numbers.
Just doing my job. I'm just doing
I
my job.
know. Okay. Yeah. Yeah. I can tell you that going into this, we were being conservative, and the numbers will naturally be better than that. But exactly where they're going to land, I will know soon.
In a little bit. So a
Yep.
few more days and we'll
Yep.
know the number. Oh,
Yep.
well, everybody's waiting, I'm sure.
Yeah. Yeah. I'll also say I'm really trying to prioritize being able to be more consistent into the next year as well. I really value, the investigator knowing, you know, year over year what they can expect. So that's playing into some of the numbers.
So it's a 2-year budget deal,
It
so you're
is.
kind of stuck
Yeah.
for a
But
while.
yeah, but that also allows us to think forward into the next year. So
hmm Oh, that's very helpful. Well, how about training grants? How is that going to be affected? Where is that going? Up, down?
yeah. So that I mean that's as I mentioned, huge priority for me. The model going into this was um, a modest decrease, but a modest decrease hurts training grants tremendously. It hurts them more than it hurts R01s. And so that's the first area that I'm trying to protect to at least have them be whole from last year.
Hmm. So that's maybe we should talk about them. Why that as a priority?
We can't do this without a good workforce, right? We need to have well-trained people going into the field, and so um, at least maintaining the training grants to me is it's a absolute essential. If I could, I would love to even grow those so that we could continue to have more people get into the pipeline. It's not it's a big part of the budget, but not as big as other things that have to be balanced. And so it was an easier place to start and say, if there's one thing that I'm going to preserve, it was going to be training.
What about the intramural program? That's
Yep.
a good place to take money, some people say, especially if they're in the extramural program.
The intramural program we are looking at very closely in the same way we're looking at any other program. The intramural program is not at all immune from scrutiny, and we are working very closely with both of the intramural programs. Um, that I I do want to say that in the time I've been here, I've been really impressed with a lot of the work that we do in the intramural program. That it's in many ways translational and clinical studies that could not be done anywhere else in the world. And so that I want to preserve 100%. I think we have to be very honest with ourselves, though, about what we do and where where we put our money in the intramural program. It needs to meet a bar that is research that is of a unique quality that can only be done here. And I want to preserve the intramural program, particularly the clinical center, as a true national resource. And so that's leaning into things that we're doing there to make sure that it's meeting the priorities that are essential for us.
That I hear you're saying that there could be some cuts there. That's me saying it.
That's yeah.
Yes. What about Frederick? Is that they trained me not to not to look at Frederick as part of the intramural program, which it's not.
Yeah, I'm learning a lot about Frederick and the intramural program, and they're really very separate. Actually, I'm working hard to make those delineations a little clearer as well. Frederick National Labs, the important uh, feature of that is that it should be it should be viewed as a national resource. So that's not just for the intramural program, that's for everyone. And it gets used in that way, but needs to be much more visibly a national resource. We are in the middle of recompeting the contract for the Frederick National Labs, as this is a long-term contract to provide the scientific support for these really massive type of projects that they do there. We have to really make sure that it's work that is essential. So I'm learning a lot about the Frederick National Labs, working closely with my board that oversees that, really trying to also just improve the visibility of the Frederick National Lab so that it's uh, a resource that others can turn to.
Is there a time to make changes, or has it been? Where's the contract recompete right now? Is there a time for you to make some changes in there, or has it been pretty much set?
So no, nothing's been set in stone. Leading into the contract negotiations was a time that there was a lot of scrutiny, but there will be more time later as well.
Okay. Um, I guess one question that I guess really needs to be asked separately is what happens to the clinical trials cooperative groups? Can they grow? Do they? What happens with the clinical trials system,
Uh,
the infrastructure?
yeah. Well, I think the infrastructure is quite stable, and I've really enjoyed getting to know the heads of the different cooperative groups. We're working closely together on looking at the clinical trials innovation unit and how it can, help support innovations in the way we operate clinical trials and the way we um, uh, uh, navigate, for example, work together with the FDA. Um, different so there's a lot of aspects of the NCI and clinical research that are growing. For example, is we've added, this is a little bit of a tangent from your question, but we added the Cancer Research Screening Network this year, sort of a network of different types of investigators than is traditionally in the cooperative group, right? This is in the primary care space where most of screening happens. So I'm really excited about that addition. So there's growth, but it happens in sort of a different way. But the overall structure of the cooperative groups is I see no changes on the horizon.
So it's sacrosanct. Uh, but well, my
It's
word.
working. Yeah.
What about cancer centers? What can academic cancer centers do at this difficult time? How can they
Mhm.
continue doing what they're doing? Is there going to be a haircut there? How do you continue to do things the way they did when,
Mhm.
five grants were high and pay lines high as well?
Yeah, yeah, I'm very sensitive to the very thin margin that cancer centers live on, right? And um, where cancer centers have historically been preserved, and in fact, great efforts to try to increase the funding to cancer centers. So this is not going to be the year for that. I can say that with some confidence. Um, we're we're looking at how to best really preserve their funding so that they can do the important work that they do. I think that the cancer center program is uh, it's it's truly a unique and really special part of our whole ecosystem one that is countries around the world and groups around the world are trying to emulate this sort of hub and spoke type model of expertise and um, focus around the basic translational, clinical, and community cancer research. So, making sure that that is retained is vitally important to me. And what I'm interested in trying to do is work together with the cancer centers to make the network really be the powerful thing that it can be. And I have not yet gotten to meet with the cancer center directors as a unit. Our annual meeting will be later in this year, and I'm really excited to hear what is on their minds and how we can really help them the best.
Well, your whole career is about cancer centers.
Right, but I was in a few cancer centers, not in all the cancer centers, right?
Right.
I
Well,
remember a quote from Ned was, "You've seen one cancer center, you've seen one cancer center,"
right.
and I've known well two cancer centers and somewhat a few others, and they each have strengths, they have similarities, they have some have real depth in one area and figuring out how we can leverage that for everyone to be I don't want them to be all the same by any means. I want them to continue to have their unique character, but to just really capitalize on the incredible talent that we have that's in these units.
I think as far as the impact of this budget, uh, will they feel it hard, or will they not feel it this year, or will they feel it next year? I'm seeing some numbers, but it's pretty much
Yeah. What can I say? They will feel it not as bad as they thought it would be.
okay. Well, I know what they thought it would be. They thought it would be 10%.
It,
Uh,
it, it will be better than that.
all right, and the 6.5% was another number I've seen as a good best case scenario. So I'm somewhere in the ballpark, right?
And and better than that too.
Oh, better than that. Wow.
Yeah.
Okay.
Yeah.
So there will be
You know,
something.
I went to business school. So that literally I went and got a master's degree. And so that I, could really learn how to, do some of these, finer accounting. Um, and
Gee.
I can't make money grow on trees, but I'm trying to, really put it where it matters most.
Well, change management is important, and
Mhm.
it's nice to look at the whole system
Yeah.
at once and see how it changed over time. Right.
Yeah. Yeah. I mean, and that's actually the part, the first question that you asked was, how I was doing. And I said I was doing fabulous. And it's because I get to see all of the pieces um, all together. And it really is a big machine. And it's really, truly, something that doesn't exist in any other place in the world to have such an operation, really focused on, ending cancer as we know it. And um, I am one enjoying getting to know it really well, but two, enjoying getting to drive it a little bit. And I think I'll only enjoy it more as I get to steer it um, going forward.
So you were basically guessing how the structures operate, right? Being in Tennessee, you were guessing how that structure operates, being on the outside, and now on the inside, you see the whole thing.
Right. Yeah. I think in any organization, it's, you know, so I tend to approach these things like a scientist. I think this is how everyone does, which is to do a couple of experiments and you see how things respond. You see what the conditions are that work. You see where the weak spots are. You see where the strong spots are. I mean, that kind of thing you can't do until you're here. I, was on the board of scientific advisors, so I thought I knew all the components, but seeing how they interact with each other, seeing how they, um, uh, some support others, really well. Those kinds of things you just can't see till you're right in it.
So there's a structure in your head right now about how it's going
Yeah,
to.
I'm still. I would say my structure, my mental structure is still being built, but it, it's uh, it's roughly there.
You seem confident about it. It's actually a couple of machines because there's also ARPA H. Is that
Mhm.
machine kind of usable in some ways? Can you put the sprockets together so that?
Yeah, that's a great question. So ARPA H, I think, is going to be a really interesting component of the whole cancer agenda and enterprise. I've been working really closely with Renee Wegersen to coordinate our efforts. Some of the newer projects that they're in the midst of launching, it really stemmed from decades of work that come from the NCI. And so it's a natural progression to move here to this sort of accelerator platform. I expect that they will learn a ton of things and come back to the NCI. So the I think the enthusiasm and energy that ARPA H has brought to people's awareness of research, I think is also phenomenal. Um, uh, I um, uh, I am trying to piggyback on some of that as well as I talk to people who otherwise don't know the real energy that there is when you're in the midst of a really exciting cancer project, all hands on deck, everybody exciting, and seeing one piece of data after another. We've all kind of lived in that when that happens. That's the kind of zest that gets us like really thrilled to be in the cancer research arena. We need to show that to people. People get it when they see what ARPA-H is doing. We do that too, but back to your original question, we're partnering very effectively with ARPA-H, and it does provide us another lever in terms of making big advances for cancer.
So they could actually end up taking some of the stuff that you might be cutting at NCI, maybe.
Yeah, and that's fine. We don't have to do everything. The work needs to get done,
Mhm.
and we're happy when it gets done well in any other arena.
NASA.
Yeah, let me tell you about NASA. So among the many really fun things that I've gotten to do in this job is I was invited to do a press conference at NASA with the administrator for NASA, as well as the Secretary for Health and Human Services, and some astronauts. So I, um, I think it's a great example of the interagency collaboration. It's to me, it was inspirational to be thinking about where we fit in terms of a space type of uh, agency, and thinking about cancer as a frontier is the same as space with this limitless potential. But we talked very specifically about the kinds of science that helps advance cancer research that can only happen in microgravity. And so just one tremendous example of interagency collaboration.
Mhm.
I had a great time.
Is there anything specifically that you can be doing?
We specifically talked about microgravity as a space to grow protein crystals because the crystal formation can be actually optimized in space and in microgravity in ways that we can't do here on Earth. And that gives us opportunities to look at novel drug design, novel protein-protein interactions, and even how to package large protein molecules for effective therapy to patients. So there's a tremendous amount of opportunity there.
To what extent is there a duplication with what industry is doing? Are there any parts of it that should just be farmed off to industry, uh, do you think?
Yeah, at NCI
Yeah,
or yeah.
most.
Yeah, so that's interesting that you asked that question because I've been asking that of my boards. I've been giving them a series of questions, and one of them has fairly routinely been, "Do you see things that we are doing that could be better done at another agency, at a foundation, or by pharma?" And I think we have to ask those questions. Pharma does more than they used to, and they can be a very effective partner. And we don't have to own the whole world. Our agenda is to make sure that we um, advance the best science possible, that we continuously see improvements in how patients do with cancer and improve the um, uh, morbidity and mortality from cancer, and that 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 involves partnerships with all of these other groups, and knowing when we're in our swim lane or when we need to pass it off.
Mhm. But also the money that pharma has at its
Yeah,
disposal is very different from what you have to deal
yeah.
with. $7 billion is a lot of money, but it's not.
But by the yeah, yes.
Uh,
Um,
uh,
I guess where I was going to go was though that um, we can, really, help good projects get to pharma, right? The SBIR is a great example. We've seen really fantastic work that otherwise would hit that cliff that that um, we can get them to a place where they can be picked up by a pharmaceutical company that then can get into the hands of patients. So we're looking for those gaps, and I mean I think that's where government fits in. Is we we can help with the work that isn't going to be done by pharma or isn't ready to get to pharma. But I agree. We need to leverage that enormous resource as well as we can.
mhm, mhm. What about the White House and the goal of the moonshot goal of reducing cancer mortality by 50% in 25 years? What's happening right now? Is that setting it back?
Yeah, no, I've given that a fair bit of thought, and so first we are already seeing improvements in mortality, and if we look from 2010 to 2020, there's an improvement of 16% in mortality. So that trajectory alone is close to getting us to the 50%. I'm not going to rest on my laurels and say, well, we're already on a good path and we'll get there. I know that we're doing better at how we care for patients, prevention efforts, and in uh, um, early detection screening than we were doing in 2010. So, and the types of therapies that are available. I mean, think where we were in 2010, right? Immunotherapy was not really even on the map yet, and here now, we're seeing immunotherapy improving survivals in cancers, new cancer every month or more. So I'm quite optimistic that the slope of that curve is already going to be changing. So I think we'll get to that one. The other part of the moonshot is end cancer as we know it, right?
Mm.
And um, I'm optimistic that we'll get there as well. That's a little bit more of a hearts and minds type of a goal, but it's not. It's helping people really own their risk for cancer, and this is education and messaging, and um, uh, research that helps us know, you know, how to prevent cancers and how to screen effectively and how to manage them. Working with agencies that provide for access to care, as well as innovate novel new therapies, right? So all of those components make it to a place where people know how to assess risk. They know how to be confident to know what is coming with a diagnosis, and they can um, approach cancer as any other healthcare problem without fear. That's ending cancer as we know it. And so I see that happening bit by bit every day. So, I do think that setting a lofty goal was important, and it helps us, have our kind of eyes on where we need to get to, and but I think we have all the tools to get there.
And none of this happens without NCI, really, because that's a
Well,
crucial.
we're responsible for the National Cancer Program, right?
Yeah.
So I take that responsibility incredibly seriously. We're the National Cancer Act really puts that squarely in our zone. Not that we are solely responsible, but it is, that lets us know, where is our focal point. Our focal point is getting to, a place where we can manage cancer as a uh, uh, lower mortality, more more chronic disease type of scenario. So we're totally focused on that.
Mhm. Is the cancer plan that Dr. Bertagnoli got set in motion, is that something that is proceeding? How does that
Yeah,
go?
I like the National Cancer Plan a lot. I I find it to be a really effective roadmap type of tool. And you've heard me just sort of roll off the tongue with um, prevention, early detection, uh, innovations in therapy, and then optimal outcome for patients. That arc comes directly from the plan. And then it has other components that I like a lot that remind us that we need to optimize our workforce, that data is essential, and maximizing data utility, uh, eliminating inequities. We know that crosses all of those different spaces. And then finally, my favorite part of the National Cancer Plan is they engage every person, because literally every person has some risk for cancer or has some stake in cancer. And we can't do this by a top-down approach. So I actually find the plan to be very useful in a wide variety of scenarios. So I'm using it uh, hopefully to its best effect.
Hmm. Yeah, I'm actually really worried, and worried specifically because the White House seems to think of NCI directors as a workforce for, plugging in the holes in the administration. Let's say if right now a phone rings and somebody says, Dr. Rathmell, we need you to run the blah, blah, blah agency, whatever that may be, FDA perhaps, whatever, NIH, not NIH, mnemonic is NIH. But what happens? Do you fear that call?
Oh, I don't fear that call right now. I have to say, first I do serve at the pleasure of the president. And so if the president calls, I will certainly listen. But um, I am in the best job there is in government right now. So I'm my mandate is to end cancer as we know it. And that's my sole focus right now. So I'm not worried about the phone call. Um, really, happy to be here and just looking forward in the cancer arena.
Mhm. Well, it's the best job in the world, and it's always just an honor to cover that. Is there any question I forgot to ask?
No, I don't think anything you forgot to ask. I will just end by um, making sure it's clear that in spite of the budget constraints, this is the best time ever to be in cancer research. That there's a lot going on in all of the different dimensions, and we can make strides today that we'll be saving patients' lives tomorrow. And it's just thrilling to be in this space. So everyone from early career to seasoned professionals, I think, should be feeling that enthusiasm right now.
Mhm. Well, thank you very much.
Thank you.